Good evening, everyone. I'm Lyle Swenson. I'm president of the Minnesota Medical Association. On behalf of all the physicians in our association and also on behalf of the Minnesota Hospital Association, I want to welcome you tonight. And I'm very pleased to have the honor of introducing Senator David Durenberger, and he'll bring the panelists up. Senator.
Thank you. Thank you all very much. You've all heard about all these private online colleges and stuff like that, so apparently I went to medical school and got myself a degree. Thank you, Lyle.
As I was thinking about health reform in this state and thinking back about my career, this year is the 40th anniversary of my graduation from medical school. And thinking back, every single year since 1972 when I graduated, health reform has been on the agenda in the healthcare field. Every single year it is, not enough people have access to care, costs are too high, and quality is variable. Every single year. And we've been working on it with all sorts of acronyms and various alphabet soup of reform efforts. And in the process, our costs have gone out of control compared to other countries, and our results haven't, the ones that they use for comparing country to country, we've gotten worse comparing to everybody else. But I have to acknowledge that I think the outcomes, and I know I'm speaking to a medical audience basically, the outcomes that they really look at, that they often hold the medical profession to, are really not under the control of the medical care system. They really are public health issues, they're social issues, they're economic issues.
The Affordable Care Act decision, as I think you all know, left every state with two big decisions. One big decision is, are we going to have a state-based exchange, or are we going to go to the federal model? And Manny Manson-Margala is going to talk about that big decision. And the second big decision that states are going to have is whether or not to do the Medicaid expansion. And that's a decision that I certainly didn't anticipate that states would have, because if you remember, originally the Affordable Care Act said, the federal government will pay 100% of the costs for this expansion population. Let me just give you the backdrop so you know what that is. So under the Affordable Care Act, actually half of the people who are going to gain coverage through the Affordable Care Act, that half of them, 17 million of them, aren't going to do it through the exchange or because of a mandate. They're doing it because of the Medicaid expansion, where the federal government says for 3 years we will pay for 100% of the costs of covering those additional people up to 138% of the poverty level, about $15,000 a year. We'll pay 100% of those costs for the first 3 years, and then it'll decline to 90%. Because as most of you all probably know, Medicaid generally covers pockets of populations, children, parents of children, but typically does not cover single adults, even very poor single adults. So that, but what the Supreme Court said is basically, states, you get to choose whether or not you're going to take the federal government up on that offer. Now, we're in a little different situation here in Minnesota because we are, as Commissioner Ellinger said, we've been ahead of this. Most states look at this, the Medicaid expansion, and whether they like it or not philosophically would say, okay, we have the opportunity to cover a lot of single adults that we weren't covering before because the federal government wasn't paying for part of that. But of course, here in Minnesota, we have Minnesota Care. And we're already covering a lot of those people, not just up to 138% of the poverty level, but far beyond that. So we had a state program that was state funded that was doing that, and it makes it a little different for us in many ways. Because if you think about it, other states are just saying, okay, do we take them off from this offer to cover people up to that $15,000 a year, that 138% of poverty level? Because remember, after that, under the federal construct, people can go into the exchange and get subsidies to purchase coverage. But we know in Minnesota Care is offered to people up to, depending on up to 275, 250%. So what do we do? How do we relook at our state programs with these federal opportunities, and they are good opportunities, in mind?
So I have the wonderful job of explaining to you the wonderful and exciting world of insurance. and particularly the world of insurance in this new marketplace that the Commissioner Jessen has talked about called a health insurance exchange. Now, the first thing that when we use that word is that it's probably not going to be a word that's going to resonate much with your patients, your neighbors, your friends. An exchange at a conceptual level sounds like someplace you go to barter with people, right? You bring in your dirty laundry, you get something in return. That's not what we're trying to create. What we're trying to create, and as the commissioners indicated, is a choice the state had to do, was to decide whether or not we, the state, were going to create an online electronic marketplace for folks to be connected to that exciting product, health insurance. Now, if we didn't do that, our friends the feds said, that's okay, we'll do that for you. My sense from living in Minnesota now for 20 plus years is we don't like the feds doing things on our behalf, in part because they tend to steal our best ideas, and then we like to think they don't do so well with our really good ideas. So at the direction of the governor, he issued an executive order in October of last year directing first the creation of the Healthcare Reform Task Force, and then part of that, directing my boss, Commissioner Rothman, to build this thing known as a health insurance exchange, to engage in the planning, design, and eventually implementation of this online marketplace.
The concern is that this is going to create more administrative burden rather than less. Again, one of the biggest criticisms of the U.S. healthcare system is that we have high administrative costs and a lot of money goes to administration. I don't see that this is necessarily going to reduce that. And so unfortunately, one of the biggest problems we have in our healthcare system is high administrative costs, and I think unfortunately this is not going to reduce that at all. And I think, again, instead of giving the responsibility to the patient, we continue to sort of perpetuate that middleman mentality where there's a doctor and there's a patient and there's an insurance company or some entity in between that is providing or paying for these services that they're receiving, and they don't have really much skin in the game. So I think we need to probably creatively figure out a way to bring that together.
What I really am going to talk about tonight are really the inevitability of change, and then I want to talk very specifically in a very short period of time, of course, about what are the essentials of response that we all have to be viable in the future. At Mayo Clinic, in my position, and with the folks I work with, we very clearly understand that unless the health system changes significantly, we do not have a sustainable business model for the future. And my guess would be if Mayo Clinic doesn't think it has a sustainable business model for the future, you're probably thinking the same or ought to be. The situation right now is we have a theoretical construct for accountable care in this country. We have very few providers nationwide, with a huge concentration in this state, by the way, that are actually capable of doing it. So what are the essential elements you must have if you want to do accountable care? You have to have a network of providers, because you're going to be responsible for your costs over time and for the quality of the patients that you have responsibility for over time. Therefore, the care network has to include collaborative activities between continuity providers in the primary care area, procedural providers, and others. You have to have a network of providers. If you've got that, you have to align their purpose. You can't have one group of providers responsible for filling beds in the hospital while another group of providers are responsible for keeping people out of the hospital, right?
I really appreciate Dr. Nessie's comments about integration isn't necessarily ownership and so on. It's coming together for a single focus. Achieve maximum integration to improve the value and reduce duplication. We have 4 electronic medical records on our campus. They do not talk to each other. The hospital platform does not have discrete data. It's scanned documents. I tell the public, I tell the community, we are the poster child of waste in healthcare. With that, think of the millions of dollars that have been spent in the little community of Faribault on a bunch of EMRs that don't talk to each other.
So I think now's the time we should thank the Minnesota Medical Association, the Minnesota Hospital Association, Janice Elbersmith in particular, this panel, and anybody else you'd like to thank tonight, because for bringing us all together. And I thought it was really a very informative session. So thank you all.